And just before, so we're going to introduce our speaker for tonight. And our speaker is Dr. Mark Sherman, and he's been here before to present to us, so it's great to have him back. He's an integrative family physician practicing at the James Bay Community Project. Graduated from McGill in 1998 and has practiced in northern communities and internationally before coming to Victoria. He uses diverse knowledge of nutrition, herbal medicine, and yoga in order to complement a firm grounding in Western medicine. He uses skills such as cognitive behavior therapy, Reiki, hypnosis as tools in his holistic approach to his practice. He's a founder and an instrumental figure in the development of the Victoria Community Health Cooperative. Please join me in welcoming Dr. Mark Sherman.
Thanks so much for having me back. Can everybody hear me back there? So, last time I was here with you all, I was speaking on complementary and alternative or integrative medicine approaches to prostate cancer, and which I've spoken to and know the research very well. And I do a lot of work with mindfulness and the effect of mindfulness on health and wellness as well. So I give a lot of talks on that. And when Andrew asked me to present on this particular topic, it was most interesting because it wasn't something that I go to the internet or to any other resource to study and to think about what we're going to say about this. It's something that's obviously very close to my heart because it's what I live and what I've lived day to day for the past 14 years. So today we're going to be talking about understanding the roles of your GP as physician, as coach, as advocate, as coordinator, as partner. And while I have a few slides to kind of frame the discussion at the same time, how many people in this room have a GP? Correct. Okay. So one of the things that I'd like to hear is I'm going to be talking about the journeys and the different roles that I have played and that GPs play in general in healthcare. But I'd also love to hear how your GP was part of your journey with prostate cancer, or with any other illness that you might have had. Because I think we really are going to learn a little bit more about what GPs do, but I think bringing it back home is what this presentation is going to be about. So
before we get started, Are you accepting new patients?
Unfortunately, I'm on record here. I am not accepting new patients. But thanks for asking.
Oh gosh, you would have quite up to this.
So your GP as physician. So here's a nice old-fashioned picture of the family doctor. So how do we get to becoming general practitioners or family medicine physicians? So we have to have an undergraduate degree in Canada, a university undergraduate degree. Then we apply to medical school and we do 4 to 5 years of medical school. And then we have to do what's called a residency program. And when all medical students, whether they're going to be urologists or ophthalmologists or family doctors, have to do the same medical schooling. When we get to residency, that's kind of what used to be called an internship. And that's when we decide which direction we want to take this medical career. And so as family doctors, we have a 2 to 3 year residency program after medical school. Now, one of the characteristics that we'll talk again and again about family doctors is they're the quintessential generalists. So during our residencies, we have to learn about respirology, we have to learn about cardiology, we have to learn about neurology, we have to learn about orthopedic surgery, general surgery, vascular surgery. We actually do rotations in all of these different disciplines because we're the first point of contact in our healthcare system. So if somebody has anything from a cough or a cold to a potential cancer, their entry door to the healthcare system is often through their GP. So we need to possess the tools to recognize when something is serious and needs perhaps more resources, such as a specialist or a specialist center, and when it's something within our abilities and skill set to help a patient. So there's always, in medical school, there's always this talk that a generalist knows less and less about more and more until they know nothing about everything. And a specialist knows more and more about less and less until they know everything about nothing. So I'm not sure I necessarily agree with the quip about generalists, but yeah, as we just were speaking to, a generalist, as a family doctor, as the general practitioner, really we're not just a triage service, so it's not about seeing your GP and we say, okay, well, you need to go to orthopedics and you need to go see a respirologist and you need to go see a urologist. Probably 80 to 90% of all diagnoses, the literature says 70 to 90, is made by the general practitioner. So we've made the diagnosis, we've often started treatment of a wide variety of different pathologies and different things that can happen in the body and that can happen to the mind. So the general practitioner is really asked upon to wear these different hats as a physician, to really have some literacy, some skill, and some experience in all of these different disciplines, and also to know where our limitations are and where maybe a specialist might be appropriate referral. One of the unique attributes that is part of this profession is that we are encouraged throughout medical school to treat the whole person, and nobody more than a GP has that opportunity to do that day in and day out. So not just treating the physical body, but treating the mind, treating the spirit. As we know in your own journeys, when we're confronted with a disease, when we're confronted with a health challenge, of course it affects our body. It affects our emotions. It affects our relationships. It affects our life at every level, particularly with serious health challenges. And so the GP is called upon to help us as people faced with a health challenge navigate this from all of these different perspectives. And treating the whole person and not just the disease. I remember being a resident physician in the hospital, and it's changed to a certain extent most of the time. But, people who are struggling with the disease in the hospital would be referred to by their disease name. We really should round in the gallbladder in room 318. Let's go talk to the COPD in room 411 over there. And, we were like, what is this? But I think sometimes, to a fault in our reductionist approach to health and to disease, we reduce it down to a disease and to symptoms, and sometimes we lose the whole person that's sitting in front of us with the various levels of challenge that the disease presents. So this is one of the benefits of being in the role that we are. And, remember medical school colleagues who went in one of many directions. Some of them are family doctors, some of them are specialists. I'm in touch with many of them as good friends. And we've had very open discussions of why one would choose a certain profession over another. And, sometimes it's intimidating to be a family doctor and to be asked to know such a breadth of knowledge, right? To be kind of the jack of all trades or jill of all trades. But we choose the profession because of these different roles. We choose the profession because it's an honor and a privilege to deal with whole people and to know families and to see kids grow up and to see people go through a health challenge such as cancer and to grow from it and to become stronger and to help them deal with symptoms and to be that coordinator and that advocate and so forth and to wear those so many hats. Yes, it has its challenges, which might veer some people away, but it's very attractive in that it really offers an opportunity to be of service. So your GP as coach. We have our typical GP there. So, as coach, we're there sometimes encouraging our patients in a certain direction that has to do with their wellness. We're experts or aspiring experts in wellness, and that we're trying to encourage wellness behaviors in our patients: diet, exercise, stress management. Whether we're talking about prevention or we're talking about living with the disease, we really are coaches in the sense of encouraging people that we're working with as patients to take care of their health, take care of themselves through a disease process in their life in general, because we know we have that expertise of how that affects their health and their well-being. Sometimes we're a coach in the sense of just bringing out the pom-poms. We see somebody doing a really good job, they quit smoking, they're adhering to a very complicated medication regimen, they've started an exercise program, they're looking at their stress or their mental health in a very proactive way, and we're just there to offer support and encouragement, and to, like I say, take out those pom-poms and just encourage them in that direction, which is very important and effective. What's one of the largest predictors of quitting smoking? The number of times it's mentioned by a GP that maybe you should consider quitting smoking. It's one of the greatest predictors. So just by being there and saying, hey Bob, hey Jill, hey Gary, what do you think about this? Has effect, particularly because there's a relationship. Anybody want to finish this for me? An ounce of prevention, pound of cure. That's right. So this is where we take our pride in focusing on. Of course, we do. I think some of the newcomers to the group have mentioned this. We do our best to take care of ourselves, and yes, we all can, maybe work in a certain area more or less than others, but our focus as family doctors is really to help all of the people we work with as patients to prevent disease. By the time you see a specialist, there's a disease process in place. So really it's our role as healthcare providers to be that front line, okay, yes, we have early prostate cancer. Yes, we have early evidence of heart disease. How can we prevent this from becoming more serious? You've had a heart attack. How can we prevent you from having another heart attack? You have a strong family history. How can we prevent this from being your reality? And this is our focus, and this is where we like to put focus. We don't like to, if we can avoid it, wait till the disease comes up and then need to react to the symptoms or to the cures. And motivating change, motivational interviewing, cognitive behavioral therapy, these are the tools that we use to try to help you as patients to confront a challenge and to create change that needs to be made. Right? If somebody's smoking, if somebody is more sedentary, if somebody needs to shed a few pounds, if somebody needs to look at their diet and how it's affecting their disease or their likelihood of disease. Motivating change, not in a wagging finger policing sort of way, but more in a, listen, we've known each other for many years. I know how important your grandkids are to you. I need to tell you, I don't know if this behavior is going to allow you to see your grandkids grow up. We can say that because we have that relationship, because we really do care about this person. So motivating change is part of it. Your GP as advocate. So I'm sure when we get to our discussion and question part of this presentation, I'm sure we'll hear lots of stories about healthcare and some of the challenges of navigating an increasingly complex healthcare landscape. Innumerable specialists, specialist centers, various trial drugs, various opinions from the internet, from second cousins, from your Aunt Mary, about what might be appropriate for you in your disease. From Dr. Oz to Dr. Google, there's just tons of information out there about what might be appropriate and what might be the diagnosis that your GP or specialist is obviously missing. And I think that our role through the tests and through the specialists and through different sources of information is to help advocate for you as a person, as a patient, in what might be most appropriate as far as information sources, as far as the best place to seek help, as far as a direction in the community or abroad that might help you with your particular health challenge. What happens with the reductionist system of healthcare is that the respirologist looks after the lungs, the urologist looks after the prostate, the oncologist looks after the cancer, the cardiologist looks after the heart, and the hospitalist in a healthcare system like Victoria sees you when you're in a hospital, your GP sees you when you're in the community. And what happens is this phenomenon of too many cooks stirring the soup. And this person added this medication, this person ordered this test, this person recommended this specialist but didn't get back to the GP, so we're not sure who's doing what. And so as your advocate, the family doctor, one of the responsibilities, and this goes back to coordinator as well, is to take all of these different sources to make sure that we have the consult reports from all of these different specialists and centers, and to advocate again for what's best for you. You know, you've been started on 4 different medications by 4 different specialists for this condition. Are they all necessary? Is that really what's in your best interest? Helping you navigate that and answer some of those questions is part of our advocacy. And someone in your corner. You know, perhaps we've seen your kids grow up. Perhaps we've known you for 20 or 30 years through a separation or divorce, through a loss in your family, through a really difficult mental health challenge, through a physical challenge such as cancer. And through that, we formed a relationship. And as an advocate, we're in your corner. We're there to support you in being as well and as healthy as you can through this complex healthcare landscape, helping you find the appropriate resources, but just knowing that there's somebody that's advocating, that's in your corner if you need. We don't certainly have all the answers. And this is what I often tell patients. I don't pretend to know everything or have all the answers, but I can certainly find an answer for you. Or I know who to ask, or I know where to look, or I know what direction to point you. And this is related. So this is our multitasking family doctor here. And again, navigating healthcare's complex landscape. You know, there's lots of sources of information, lots of different aspects of our healthcare system. Navigating this and coordinating this is one of our roles. He said, she said. You know, you ask 4 orthopedic surgeons for an opinion, you get 4 opinions. And this is what often happens. And so, and again, when we look to Dr. Google and to Dr. Oz and to our second cousin for sources of information, it doesn't mean that they're not valid or very important sources of information, but our job is to help coordinate those different sources. And instead of increasing your anxiety or sense of overwhelm on a certain health topic, to help weed out what might be really relevant to you. Tests and drugs and appointments, oh my. So, when you're faced with a serious health challenge, and I know that most people in this audience know this better than I, there's a real sense of overwhelm, with a diagnosis, with that place that the monkey mind goes to where you start thinking about the what ifs. And what if this happens? You start looking on the internet, you talk to people, and you hear stories, positive and negative. And sometimes navigating through all of the tests and all of the drugs and all of the appointments and having that person that's your point person, again, that person in your corner, you can come back and say, you know what, I had 10 minutes with Dr. Scott and forgot to ask this question. Or Dr. Scott mentioned something about this drug or this test that you needed to order, I don't really understand it. We can be that coordinator that, again, we might not have that exact answer, but we can call Dr. Scott. We can advocate for you, we can find out what Dr. Scott meant, we can look up that drug, give you sources to find more information about it, and be that coordinator for your healthcare experience. And probably one of the most privileged roles that we play is as partner. Healthcare, we're taught in medical school and through residency, whether we're generalists or specialists, we're taught that this is about person-centered care. This is about patient-centered care. We're patients in one of our roles, but we're fathers, sons and brothers, uncles and aunts, husbands and wives. We're patients when we walk into a hospital or a clinic, and we be one hat that we wear. But healthcare is really, or should be really, about person-centered care. It's about you, it's about your team. So, as GPs, one of our roles is being your partner, getting personal, knowing you, knowing your kids, knowing what's important to you. I might have my own biases, my own stigmas of what I think health and wellness is. That has some importance. What I want to know is what your health and wellness, what your priorities are. Like I said, if I have a patient who's just gets so much of their grandkids, then I know that their motivator is they want to be around there for their grandkids, for their kids. We have to get personal. We have to have a relationship that's formed on trust and respect. And that's one of the privileged roles that we have as GPs, that you don't always get as a specialist. There's our person-centered care. And through thick and thin, as I was alluding to before, having been a family doctor for the past 12, 14 years, yeah, I've seen families grow up. I've seen families break apart. I've seen relationships go from dating to 10th year anniversaries, kids. I've seen tragic losses. I've seen really difficult, overwhelming health challenges. And I've seen people emerge from those health challenges stronger, greater. And I've seen people really be overwhelmed by those challenges. So having somebody that you know that you have a trustful relationship with is such a key and privileged role of being a general practitioner. And I know in mental health care and in motivational change specifically, one of the greatest predictors of people adhering to medication, of people following through with a suggestion such as quitting smoking or starting an exercise plan, throughout the literature, no matter the particular area or arena, it's the relationship you have with your physician or your healthcare provider. If you have a trustful relationship, there's more likely to be a change for you to follow through on a suggestion. If there's not, unlikely. In mental health care, the relationship with the psychotherapist or the GP is one of the greatest predictors of remission from depression and anxiety. Makes sense. And we have many other roles, and this is where you come in. Sometimes we're asked to be a counselor, or a nurse, a social worker. And sometimes people have real social challenges, housing challenges, trying to navigate a disability trying to find resources for their family because they're on a single income. There's not just a social worker on the line with a phone all the time if these people are not in hospital settings or tertiary care settings. So sometimes we're on the phone, we're trying to find out, internet surfing, talking to colleagues, speaking to social workers that might work in the system. How can we help this person? Teacher. The word doctor is actually derived from the word teacher. PhD is a teacher of philosophy. And so as doctors, we're asked to be teachers, we're asked to be providers of knowledge. Confidant. That speaks to the role of GP as partner. And friend. Remember when I was in medical school, which wasn't that long ago, they still talked about, professional relationships and therapeutic distance. We were asked to, certainly be professional, certainly be friendly, but to have a certain therapeutic distance to make sure that we didn't become too close to our patients. And I remember reading a quote from a physician that I respected an awful lot, who was a senior physician who retired. He was 81 in Montreal where I trained. And he said in one of our journals, this CMA, the Canadian Medical Association journal, he said the secret to the care of the patient is to care for the patient. And so I think being a friend, being friendly, obviously with having boundaries, is an essential part of what we do. And it's one of the roles we're called upon every day. So this is the part where I would love to hear from you. I know that most of the people in this room have had your own health challenge. And from the show of hands early on in the presentation, I know that most of you have a GP. So what has been your GP's role or roles in your health journey, in your struggle or challenge with disease?
Doctor, I'm hoping you can give those of us who don't have a GP some guidance. I came here from California in October of 2012 on a consulting assignment. When my assignment was complete, I liked it so well I stayed. But I haven't been able to get a GP to accept me. They all say I'm too busy, I've got all I can take. Can you give us some guidance on how we establish a relationship with someone like you?
Yeah. Greater Victoria has 30,000 people without a GP. 30,000. It's a crisis. This is one of those places where I would say I don't have an answer, but I'll try to find you. In that it's something that we get dozens of calls every week asking for accepting. And we have 8 physicians in our clinic, so we're quite a big clinic. But all of those physicians are chock-a-block, and it's challenging. I think that the Victoria Division of Family Practice, which Bill alluded to in that communication, is an effort to get GPs together to look at some of these issues. It's not that GPs don't want to accept a new patient. It's that right now, and some of you might have this experience, it sometimes takes 2 to 4 weeks to get in to see your GP because the practices are so full, and so full with people that really have quite complicated or high healthcare needs. So accepting one more patient might seem very simple, but it just means that all of those patients get pushed off more, and then when you need to provide a sense of urgent care, it's difficult to do so. So it's a huge problem. The average age of family doctors in Victoria is not too different than the average age of everybody else in Victoria. So there's lots of physicians that retire, and there's not enough younger physicians coming in. So we have this new condition called the orphan patient, right? Where a family doctor with 1,500 patients deserves to retire at some point and decides to do that, or decides to move, and then what happens to those patients? So we are looking at solutions. I don't think that there's any clear one, but I think that we're working with each other and trying to come up with how do we attract younger physicians to this community, how do we convince people that family practice is a worthwhile arena to work in, because I think that that's the other thing. Is, a lot of new grads are finding that being a GP has lots of challenges, and they could perhaps make more money or have less, hours in the clinic if they were this specialist or that. So I think making family medicine attractive, making Victoria attractive, and coming up with ways with our existing resources to be able to take on new patients is kind of the question that we're asking right now.
Thank you.
Pleasure. Please.
Yeah, well, I don't know if I'm right, or probably not, but the government gives this big pile of money to the physicians. And then they say, the specialist gets so much, this guy gets so much, we'll give so much to the GP. And there's nothing left for the GP. I mean, they don't make huge money. I mean, you could be a nurse, someone said, you can always make so much money. So what's the solution? Are they trying to make it there is no GPs?
Yeah, this might be a can of worms we're opening up here. What I'll say is, again, there's lots of politics involved. There's lots of people that make decisions very high up of who can bill what and who makes what money of the healthcare dollars that are allotted by the ministry. I think they're trying to make it a more even playing field. I won't go into the details of how they're doing that. There's not a single person in the ministry, not a single person in the island Island Health Authority or any other health authority in this province that doesn't know lack of GPs and so many people being orphaned and not having a GP isn't a huge issue. Again, with all of these roles, if you don't have that role, when you are faced with a health challenge, what do you do? Who is the person in your corner? Who is your advocate? Who is helping you coordinate all of these tests and drugs and things? So we know it's a huge issue, and I think they're trying to address the political and economic needs and solutions to make it a more, again, attractive profession to be in. So we have more of them.
One of the topics I thought you might get into and look for our reaction on is what we can do as patients, what we can do as partners in it to optimize it. Realizing that the doctor has limited time, what can we do to make the partnership work better?
I think it's a great question.
Sorry, could you repeat the question?
Yeah, the question was, Dan was saying that what can the person as patient do to help that relationship with the GP? GPs are obviously busy trying to see as many patients as they can and trying to still fulfill these roles. What can a person as a patient do to help that partnership? And I would say that there's a number of things that are very helpful, in my experience. One of them is when patients, number one, arrive on time for their appointments. Is when we have such chock-a-block full appointments is really important, because if we have a no-show and people are waiting 3 weeks to come in, that's huge. But when they show up in the office, if they're really clear about what they want to talk about or what their priorities are that day, that's a huge help for us. Because sometimes patients will come in and a little list will start rolling onto the floor and number 112. And realizing that, none of us doctors have ever chosen to do fee-for-service medicine and to try to need to see patients every 10 minutes. It's not a choice that most doctors would make. It's kind of imposed upon us. That's the rule of the land. That's how we get our billings in. So there are pressures with so many people leaving family doctors to see people in a time frame. So I think that mutual respect of me when a patient comes in, respecting that you have your priorities, and that mutual respect, respecting that, I do have time constraints for that appointment, but I'm very willing to talk about items 5 through 10 at the next appointment. So I think if you come in with, even if there's 10 things that you really need to discuss, what are the top 3? What are the really 3 things? Because what is so frustrating for patient and physician alike is you've talked about the 3, 4 things, the physician's running 10 minutes behind, you feel like you haven't really been heard, and as you're going out the door, you're like, and I've been having this crushing chest pain. Because you haven't talked about the most urgent, the most significant thing that's affecting you. Or, it's a sensitive area of your body, and so you don't really want to talk about it, so you're talking about 5 or 6 things other, and then the time runs out and you leave frustrated, and the physician doesn't know that there's really a big issue. So I think being very clear about what you hope to get from the appointment, such that that time management is there. Nobody should be seen in 3 to 5 minutes, and I know that there's physicians in our city that do that. I don't think that's good medicine. I don't think it's necessary. But we do have some time constraints, and I think if there's a mutual respect, that's very helpful. So that's one. I think showing up for appointments, I think being clear about the priorities. And I think the biggest one, when we were talking about physician as coach, taking care of yourself makes our job that much easier. And following through, with things that we discuss together and decide together. So, I think gone is that family physician vignette that we showed in the first slide, where the family doctor says, okay, Bill, you're going to exercise 5 times a week, you're going to eat your vegetables, and you're not going to be stressed anymore. And you just listen because your doctor told you. That's gone. I'm not sure if it ever worked. It's now this patient-centered care where we work together to figure out what your priorities are and how we're going to get there. With my knowledge and skills and experience, with your excellent knowledge and experience of who you are and what's important to you. So I think when we make that decision to quit smoking, or when we make that decision to exercise more, be active, when we make that decision to look at the work stress, it's helpful to you and to us to follow through on that, right? And to take care of yourself, because, as we said before, prevention is really the path of cure. Any other questions around that, please?
Under the entity of a community clinic where people show up, typically they have things that otherwise in the past would have gone to emergency for, but they show up, particularly with their kids sick or whatever. So the number of doctors that are there and available, and you wait in line. When you go in to see the doctor, do those doctors have a caseload? And the second question I have is, do they have access to your medical records that would include reports if you've been to other specialists and other people in the medical community? Can they see those records?
That's an excellent question. Quickly, the answer to the last question is hopefully soon, but not now. But when you go to a walking clinic or to a community clinic, there's some fantastic physicians that work at some of these clinics, and they are providing such an essential service to so many people without GPs that I think kudos to them. As a model, a lot of us as family doctors aren't, in an ideal world, huge fans of this model, simply because things like continuity, things like relationship, things like some of these roles that require an ongoing relationship. Now that being said, there's a lot of people who don't have GPs that go to the same walking clinic and see the same one or two physicians time and time again. And so, maybe it's an imperfect world and we develop those relationships and that GP has some of those roles. The problem is, and I'm sure that's been some of our experience, more often than not, you wait a long time, you see a different GP who doesn't know you. And so you're starting off from scratch trying to tell them, well, I have prostate cancer and I've already been at this, and what I need today is this. And they don't know you. There's not that relationship of trust and so forth. They don't, by any computer system right now, have any direct access to your medical records. The only records they would have access to are the records if you've been to that walking clinic before and they have a paper chart. The hope and the plan over the next 10 to 20 years with most of the health authorities in this province is to develop a common electronic medical record that communicates between the hospital, every GP's office, and the walking clinics. We're not doing that in a long shot. There's about 7 different softwares, electronic medical records that don't communicate with each other that are in the community right now. And there's still lots of GPs that have paper charts. So yes, you can get that information if after you finish seeing the patient, you have your receptionist call the hospital, get those records faxed over, and then the next time you see them, you might have some of that stuff, but not during those 10, 15 minutes you might have with the physician.
Take it a little further, you go to a specialist, you have some results from their findings and tests and whatever, can you ask for copies of that to be sent to a clinic doctor?
Absolutely. Absolutely. And because there's so many people that don't have family physicians right now, there is a technical rule that if you've seen a patient, I think it's 3 times is the rule, then you are in healthcare lingo, you are an MRP, you are a most responsible physician. So it doesn't mean that you're their family doctor right now, but you're as close to it as they have. So, you're the most responsible physician, so as far as whether they carry a caseload, in that respect they do, but there's not the same continuity that you would have with a family physician. Oh, we really opened this thing. Please, in the back first.
Just to follow up a bit on what Alan was talking about,
Yeah.
I want to throw an example out that our family was through last fall, just to talk about this mix of family physicians and walk-ins. We've always had a family physician, but the family physicians work as part of a walk-in clinic as well, so their time is split, and that's a question all in itself of how the parameters shift between those 2 roles, and that's one question. But I want to give you an example of what happened to us last fall. We had a situation where one person had over a situation which was difficult to diagnose, whether it was a mini stroke or what, but it involved emergency, it involved over a period of 3 or 4 months, a whole raft of tests and a whole raft of different specialists. But in our own clinic, the GP that we had went off all of a sudden on leave for 3.5 months. Over that period of time, we had 2 other doctors we already knew in the clinic who said, oh, we'll look after this on a committee basis. And that was his word, not mine. And we're at least 2 locums in that period of time. Over that process of that 3 or 4 months, there was a whole string of specialist reports and so on, came back and forth. It became an absolute nightmare in terms of having anybody who actually knew. We weren't even sure who was getting what reports at some points in time. And I just wondered what your sense is. I want to throw this out because I'm sure other people in this room have had similar experiences. What your sense is of what happens to that coordinator role you talk about, especially the way things happen in terms of limited referral times to specialists, where you have to keep referring if you don't get within a limited period of time going back. What happens for people who don't have GPs who are in that coordinating role and have to find some other way that you don't just lose information, let alone get to the people you need to go to?
Yeah, and I think that's one of the roles of the MRP that I was talking to. So if you don't have a family physician, you do go to a walk-in clinic. If you have a multi-doctor clinic, as I think you're alluding to, like our clinic, if I'm not there, and they might see a locum, or they might see one of the other physicians there, we share an electronic medical record. So your medical record and all of your reports are funneled to one location. Different doctors can sign in to see that record, but it is in one place and all of the information is there. So it's not perfect, it's not that same relationship with the person you've known for 10 years, but at least, as you're saying, the information's there. If you don't have a family physician, or you don't have one of these multi-doctor clinics, you're going to walk-in clinics, then that's the MRP. If you've seen the same physician a few times, you've gone to the same clinic a few times, you make sure that all of your specialist reports go to that center. They have a paper chart review or maybe an electronic medical record. And again, they'll all be funneled into there. So even if you see Dr. J on one day, Dr. A on another day, and Dr. C on another day, they have access to a singular chart with those referral letters. What's difficult is if you have a family physician that goes on leave or retires, and then you're going to walk-in clinics and your chart's in limbo. That's a whole another problem that doesn't have easy solutions, but we can talk about that if it's necessary. Yes, sir.
Can you speak a little bit about how a GP chooses a specialist, that referral process?
That's an excellent question. Sometimes it's by experience. We've met a certain specialist, we've had patients see a certain specialist and have really positive experiences, both in terms of skill as well as relationship. Sometimes with certain things, it's the fastest person we can get in with, because we trust the group of urologists in town, and we know that Dr. McCauley has the shortest wait list right now. So we know that you just need a biopsy. That's what you need right now. You need a diagnosis. And so we know that the quickest way to do that is through Dr. McCauley. So sometimes it's a time thing, sometimes it's we've been in this community for 10, 12 years, we know the specialists that we trust and we send lots of patients to, and we are very good relationship with them, and those are the ones that we choose. Sometimes there's a new specialist in town who will see someone for potential knee replacement in a month rather than 6 months. And sometimes we'll take a chance there. Obviously discussing our reasons with the patient. We don't make these autocratic decisions on your behalf. But we say, listen, I've had really good experience with Dr. McCauley. He's got a relatively short wait list right now. I think that what we need is a diagnosis, and I think that's the place I'm going to refer you. And I've had patients say, no, not that doctor because of this. My cousin was here. That's fine. So we're not attached to any one specialist. But I think we'll have that discussion of why we're referring in a certain direction, and if you're in agreement, then that's what it's there.
And a quick follow-up, if you're referred to a surgeon for a surgical procedure, how does a person make a valid appraisal of that
physician's ability to deal with the situation? Do you just go on the faith of your GP's referral, or?
Well, your GP won't give you an opinion.
Yeah. I mean, I think that there's different ways. You know, there's Rate Your MD, which is online. It's, there's lots of patient-oriented survey sites on the web where they actually have every doctor you can imagine there with 1 star, 2 stars, up to 5 stars, and really a lot of anecdotes from people that have had surgery with that surgeon, have had a somewhat clinical relationship with that surgeon, so you can do your own research in that regard. But you know, again, if you have a long-term relationship with your GP and they're referring you to a specialist and they say, this is why I'm referring you to this particular surgeon for this particular procedure, at some point you trust them.
So you have 2 surgeons, right? A and B. Okay. A surgeon has only 5 complaints, people writing about his review, right? And B surgeon has 25 complaints. But you might presume that A surgeon's patients aren't around to complain. So it's not always good just to have.
It's a fair factor to take into consideration.
In terms of medical records, that I find myself in a bit of a quandary on that, in that you like to think that the doctor is able to make candid comments for his own purposes. And yet, me as a consumer, I'd like to know what's in there. I'd like to know that whatever the doctor has, Dr. A, Dr. B, Dr. C has, I have full access to it so that I can verify its validity and that. Any comment about how we can go about getting copies of our material?
So there's actually huge medical legal opinions about this, and there's a whole bunch of specialists in town who have a cover letter saying no third party, other than the physician generalist and the physician specialist, which the letter is in between, are privy to this without express written permission. Right? So they're basically saying patients, ICBC, WCB, insurance companies cannot look at this without me saying it's okay to look at it. I think that that's wrong. In our clinic, as some people who attend our clinic can attest to, whatever's I have access to in the chart, you have access to in the chart. If you want a copy of the specialist consult, I'm fine with that, and I will take on that specialist if they have different opinions. They are providing information and opinions on you. So you have every right to have an opinion. And I think that there's still, as far as what the law says, it's still iffy. Because there's a lot of doctors that don't feel that the patient has right to absolutely everything. And there's valid justifications, valid arguments for that as well. You know, they might not understand the language, they might cause undue anxiety. So I understand some of the reasons, but I generally feel like if you have a physician who can go through it with, and not just blindly copy it, but go through the concept and say, this is what this means, this is what the specialist is trying to say here, this is the opinion, take it home and add it to your file. The future of medical records, and they're already starting this in many HMOs in the States, is a web-based electronic medical record. Whereas you have your login to your clinic, you look at your chart, you make your appointments online, you see when your specialist appointment is, you look at your recent lab results, you look at your x-ray, you see the consult letter from the specialist from your home. You enter in password, there's firewalls, there's privacy, protection, but that's the future. It's already happening.
Well, yeah, sorry.
I did a trial 5 years ago on that
Okay.
at the cancer clinic here, and it was great. I went online, and my whole surgery procedure, the doctor's report on it, was all there for me to look at and everything, and it was the best thing. And I got all my doctor's reports, everything back in one place, and I would read them, and I kept a file myself for when I went in, because then it allowed me to think, oh yeah, you said this on your report was this. Can you explain that a bit more to me, or I have a question out of that, and it was wonderful. But that was like 5 years ago, and it still hasn't really gotten anywhere. But I was hoping that all that would basically be there available. But I know with my doctor, GP, he'll give me any report I want to have and see. And he just says, do you have a copy of that? And I said, yeah, I've already got the blood work copy from, online, but any other reports, he's willing to give me. And I have back from like 20 years ago, my red cell counts and that, and one time he thought, oh, it's a little low, and I said, well, actually, it's been between this and this for the last 20 years.
Let
And
me
that's
show you.
my normal rate. And so it's really interesting when you do know your own bodies, as a sense, from these tests and results. It really helps you to be able to, oh no, well, that's kind of how I normally am. It may be low on the scale, but I've always been this way, and I function at that level or whatever.
And the fear side of the argument is obviously saying, if you have more access to more information, but you don't necessarily have the knowledge to interpret that information, does that cause undue anxiety and suffering to the patient population? I think the balance is, it's empowering. You find out what that means. You ask your physician, why is this red blood cell count a little bit low? They explain it, they reassure you, trust them. And the next step is it's web-based, and on your website, in addition to your chart, there is links to the latest article on prostate cancer research and treatment. There is links to wellness tips for having a prostate healthy diet. So it's almost like your website is access to all your information, which is empowering, but also access to that health information from a credible place that you mutually agree is useful, that you can look at that and you can empower yourself and make those changes that you need to make.
We can continue to dream about that. Ontario has spent $1 billion and has had to start over again. They made such a mess of it. I happen to know that BC has spent hundreds of millions of dollars and have an absolute mess. They're still arguing about who's going to put the data into that. Are the doctors going to enter their data? And if so, the doctors want to be paid for that, right? And not only who's going to access that data, but who's going to do all the entry and who's going to manage it. BC has made an absolute schmozzle and calls you to cry of trying to introduce electronic records.
Yeah, and I think that it's a whole other discussion of some of the challenges of introducing electronic records. I think the great thing is the largest health cooperative and one of the largest health corporations in the United States uses such an EMR. And we're talking about patient populations of like 250,000. And they have this very workable, tried and true example. So I think learn from precedent. Any other questions?
One quick follow-up on that whole thing about the records. Do you recommend that people, individuals come in, especially if you may be waiting different doctors, keep what you might call a 2-page sort of health record of their own, so that when they can go in, significant events in their medical history can be put in front of somebody and you don't have to spill it out every time you come to talk to them?
I think in this healthcare climate, it's necessary for each of us to have a really solid knowledge of where our health is, what you don't have to know the absolute detail of what number, your red blood cell width was on the last blood test, but just generally knowing what the challenges are, what the normal abnormalities might have been on your blood work, having a 2-page summary, being able to, never mind with the piece of paper, just give a 2-liner, this is who I am and these are my health challenges, and this is what I'm working with and who I'm working with, is essential, because you might be seeing somebody in 10 minutes that has no idea who you are or what you've been through. And so I think it behooves us to have that.
Just wondered, how difficult do you find the question if it's asked? If you were in my shoes, my circumstances, who would you go to?
And what would you do?
Yeah. It's tough, and I think my answer usually starts off with, I'm not in your shoes, and I don't know all the circumstances that your life is, that your challenges are not in your head. I don't know what, every priority you have. I might know what disease name you have, what your Gleason score might be, what you've already tried, and what your family history is. So, I think I would all we would do is take all of that information and say, with this stage of disease, knowing what I do know about you, I think seeing one of these two specialists would really be a good move. It's rare, and I mean, I think as family doctors, especially because we have such personal relationships, we do try to be as honest and genuine as we can be with any questions, even if they're challenging like that. But I think we're still trying to say, I'm not in your shoes and I can never be in your shoes. But knowing what I know, this is what I would recommend in this way.
Have you and would you choose one specialist over another?
There's certain specialties in town that I would, and that's, absolutely overflowing, filled with my own biases, based on patients' experiences. And, I don't know all of these specialists personally. I haven't had surgeries from all of the surgeons, so I can't speak from that direct personal experience. What I can speak to is the collective experience of 2,500 patients that I've seen over the years, that have seen the various specialists in town, from a personality standpoint, from a professionalism standpoint, as well as from a knowledge and skill standpoint. And that's how, in some very rare cases, I would say, I would definitely recommend this person.
But I don't mean all my questions to be mean negative, because I think we have an incredibly high standard for the specialists that are actually in the
We do. We have fantastic specialists, and really, I think even if any GP, including myself, says I would choose this specialist for you, knowing your circumstances, over this one, you have to realize that we're human too, right? And we have our own biases, and even though we might have 2,500 patients that have seen specialists in this discipline, doesn't mean that that's the absolute truth. Right? There could be a very good specialist appropriate, and that just isn't within our capability to know.
So I want to thank Mark very much. I guess I was fortunate to have a doctor who basically emulated a lot of the things that we portrayed there, but he became unwell himself, and so now I have another doctor, and I wish you'd go and talk to him about these roles. It would be great. I think what's been there are a couple of things that have been really helpful tonight. I just think about wellness. I think so often my own experience is, I'm going to the doctor when I'm not well, and the wellness part, the prevention is just so important. I think given the current state of our healthcare system, we've got some clues of how to be a better patient. And I think even, I know with the GP I go to now, I have my little piece of paper when I go in about the things that I need to say to him to remind him about my own situation, because his time is very limited, and we all have that experience. And I think those of you who are going to clinics, you've got some clues of things you can go prepared for, and the information to give them. I think that's useful, because that's just a reality for us now. So it's been great. Thank you very much, and coming again for the second time.
Absolutely.